Hello, and welcome to the No Bad Questions podcast, where I try to learn in a conversational manner, to break down jargon, and to present the least amount of filtering as possible on a wide array of topics. I hope that you learn something too. If you do and want to support the podcast, you probably already know all the ways that you can do so. You can like, share, subscribe, hit the notifications, but ultimately, and what I hope you choose to do, is watch to the very end. With that, we'll start today's podcast. Hello, and welcome to today's episode. My guest today is Dr. Edmond Hooker. Dr. Hooker received his BS degree from Hampton-Sydney College in Virginia. He earned his MD degree from Eastern Virginia Medical School. He then completed his residency training in emergency medicine at the University of Louisville. Since 2003, Dr. Hooker has been teaching in the Department of Health Services Administration at Xavier University in Cincinnati, Ohio. He teaches medical terminology, clinical medicine, and population health. In the spring of 2007, Dr. Hooker earned his doctorate in public health from the University of Kentucky. In 2015, he was promoted to professor. In 2020, Dr. Hooker won the Teacher of the Year Award for Xavier University. Dr. Hooker continues to work clinically in the emergency department, and he also works for Concentra as an occupational health/urgent care physician. He's the Associate Director for Accreditation for the Masters of Health Services Administration at Xavier. He has an active research agenda with over 80 peer-reviewed publications. Dr. Hooker has been married for 32 years and has 4 adult children. Dr. Hooker, thanks for agreeing to be on the No Bad Questions podcast.
Well, thank you for having me.
So, what are hospital-acquired infections?
Well, a hospital-acquired infection is an infection you get when you go to the hospital, or we actually like to kind of change the term to healthcare-acquired infections. So anytime you interact with the healthcare system and you came in without an infection and you develop an infection, that is a healthcare or hospital-acquired infection.
And why would the average person, the average consumer, the average patient care about these?
Because it can kill them. That's the ultimate bad outcome.
I hate to laugh at that, but I mean, it's a good response.
Like, it won't affect me. Well, we end up killing, somewhere between 30 and 50,000 people a year with healthcare-acquired infections. But don't even stop there. That's horrible. That's like crashing a 747 every day. You would think people would deal with this if we looked at it that way. The airline industry, if they started crashing a plane every day, everybody be up in arms and this problem would be fixed. But for some reason, it seems to be acceptable in healthcare to have a bunch of people die every year from healthcare-acquired infections, which is obviously completely unacceptable.
Right.
But also, people get infections. So someone gets a knee operation and they get their knee replaced, and they get an infection. Well, if it gets infected because you went to a hospital that has a higher infection rate, you now have to go back to the operating room, remove your brand new knee joint, throw it in the trash can, put in a sponge, and keep that in there for 6 months, and then bring you back and put a new knee in. So you can't work, you can't do anything. So it's not just killing people, but it's all the horrible things that happen to people. You know, you get a appendix taken out, and then you get a wound infection. That's a hospital-acquired infection. And maybe they didn't clean the OR well enough. That's unacceptable. And so it really impacts people's lives. It can kill people. And so we really have got to do a better job of this.
And so to some extent, if I'm the average I work in healthcare, you both work and teach in healthcare. Perhaps we're more used to this. I hate to use that phrase, but average Joe or Sally who might listen to this, maybe this is news to them. Should they be like terrified of healthcare now? I mean, what?
Well, I think you should have a respect for it. I think that you can do some things, again, shaking in your boots doesn't really help anything. So
Right.
let's see what can you do as the average consumer to protect yourself. Well, there's a few things. First of all, a simple one is, in general, don't get operated on at a hospital, get operated on at a surgery center. They tendency to be cleaner. They tendency to have much lower infection rates because they don't accept the complex cases. Those all end up at the hospital. So that's a simple one. Just say, hey, listen, why can't we do this at an outpatient surgery center, not affiliated with the hospital?
Mm-hmm.
Well, it could be, but in general, a lot of them are independent. So
Sure, yeah.
That's a first simple step. Second step is to figure out, well, which hospitals have the lowest infection rates. It really doesn't track with the doctor, it tracks with the hospital. So
Interesting.
And it's really hard to do that. There is a website called Hospital Compare. It's run by Medicare. And basically almost every hospital in the United States is a Medicare hospital. They accept Medicare patients. So if they accept Medicare patients and get paid by Medicare, they have to participate in Hospital Compare. And Hospital Compare is a clunky government website. Sorry, I wish I could make it better. But if you take the time to go there, you can say, well, I want to compare, 3 or 4 hospitals that I'm considering. And then you have to kind of go through some steps. You look for infection rates, basically, and you can compare them. And they compare them, and they'll tell you number of central line infections, number of wound infections, number of all of the different types of catheter-associated urinary tract infections. Any one of the different types of big infections, C. diff infections, which is a horrible one. So they track it. It's clunky. It's hard to get in there. Sometimes you might save yourself the hassle. Look for a recent article. A lot of times local newspapers will pick up on these and will compare infection rates. I'll put a table in the what I'm trying to say, local newspaper. So that might give you a comparison. The only problem with that is that the data is a little bit old. It's 18 months old by the time
on the Hospital Compare website. It's 18 months. Okay.
Because it takes them a while to clean up the data and get it all done, and it changes quarter by quarter. So a hospital that is actually doing better is going to take a while before their numbers on the website to look better.
Right.
But, it's one of these things that hospitals in general are doing an absolutely horrible job of cleaning the hospitals. It's one of these things that all the hospitals need to be pushed by the community, by individuals, by the doctors, by the nurses to say, no, you've got to clean better.
And I want to be clear on something regarding that a couple years ago we wouldn't have to ask. That's not a new thing due to COVID, right? It's not like COVID has stressed the resources so much that hospitals can't keep up with cleaning. This was a thing, I forget, what was it, the early 2000s that a report came out on from the NIH or IHI or whoever on like 100,000 lives a year. Yeah. So can you speak to that a little bit about what causes hospitals to not attend to this perhaps as much as they should?
So, again, I don't live in the boardroom of a hospital.
Sure. Fair enough.
But what I can tell you is I think the people running hospitals are typically very mission-driven, wonderful people. They would never, under any circumstance, knowingly let someone get an infection. That's not what they're doing. What's happened is they are trying to clean hospitals. The bugs have gotten nastier. Okay, so you got to do more to get rid of them. And simply put, there isn't enough resources being poured into environmental services, which is the housekeeping department. They are asking too much of these individuals. A hospital room, typical hospital, is giving a housekeeper or environmental services is the term we prefer to use, but I think more people know housekeeping than people. So I'm going to kind of use that term with no disrespect. It's just,
Sure.
I think people understand it better. So the housekeeping department, they come in and they're given 30 minutes to clean that room, top to bottom, everything from the toilet to the bed. It's simply not enough. It's just not enough time. The bed itself, which is what you're going to lay on 24 hours a day while you're there, okay, probably takes over about an hour-ish, 45 minutes to an hour to clean. And you've only given 30 minutes for the whole room. So there's a huge disconnect. The environmental services or housekeeping people are the lowest paid employees in the hospital.
High turnover as well.
And so because of that super high turnover, they're exposed to nasty, dirty rooms, blood, and all sorts of horrible stuff that I will not describe for your viewers. I think they can get the idea of all the stuff that would be there. And so it's a hard job. And they're trying their best, but they're just simply not given enough time, because what happened in the last 30 years is we have collapsed down the number of hospital beds. We've cut it probably in about half. Hospitals don't have any excess capacity. In the 1970s, typical hospital ran at about 70% full. Okay. Now a hospital runs at 110%. Wait a minute. How do you run at 110%? You let people wait in the waiting room.
Right.
You let people wait in the emergency department, needing admission for sometimes days. That's bad. So, well, you're like, well, why is that happening? Well, it's happening because the nursing shortage that was created by us getting rid of LPNs out of the hospital in the 1980s, and then now this push for the last 20 years to get rid of anybody that doesn't have a bachelor's of nursing, which is wrong. It's not appropriate. I'm sorry. You get your registered nurse degree from a hospital or from a online or whatever. You have all the clinicals. You are a nurse. You're a great nurse. Thank you very much. And getting all the additional classes for the masters, or excuse me, for the bachelor's doesn't change your ability to be a great nurse. But
yeah,
anyway,
it teaches usually more, I think, leadership and, maybe understanding clinical studies and things like this, right? I don't know. I'm not a nurse, but I feel like I've heard from bachelor's prepared nurses that it's not generally additional clinical training. It's more academic and managerial training.
Exactly, which doesn't. So to say that we need everybody to be a bachelor's nurse, when I push the button, and I was just recently in the hospital myself, when I push the button, I really want a human being to come, okay?
Right.
And creating a nursing crisis is just not a good thing. And then, of course, COVID made it much worse because the conditions that the poor nurses were working under was unacceptable.
Right.
But anyway, we need to get back to healthcare-acquired infections. So now we have no capacity. So these EVS workers are required to turn this bed over very quickly because I've got 40. A hospital I used to work at would have 45 patients in our emergency room, sitting in beds, waiting for an inpatient bed. I mean, come on. So they're trying to turn this bed over quickly and unfortunately are not cleaning well enough. So it's a huge issue that we can go in deeper with specifically the hospital bed, if you would like, at this point.
Yeah, I think there's a couple things that we just talked about that we could unpack. I'd love to talk more about the beds because I think you've got some technology that you or some students of yours or both in collaboration have worked on. But I would like to go back briefly to the Hospital Compare website, because one of the things that you mentioned was you can look at hospitals, but that, if possible, and I'm sure my healthcare finance colleagues are screaming at the screen when they hear, don't go to the hospital, go to the surgery center, the freestanding. But we'll brush past that and just say, does that site allow consumers to compare hospitals and those freestanding centers?
No, the freestanding centers are not on there. So unfortunately, and the physicians aren't on there. And the problem is, there is a physician compare that's somewhere in the the universe that they're working on that I just don't think is there. It may actually be up, but I just don't think it does what you need it to do.
Right.
So you really would like to be able to compare at all levels, but it's not there right now, unfortunately.
And then I know there's third parties out there, and without asking you to cast judgment on any of them or mention them by name, we'll just say, people will hear about these outside agencies. Your local hospital is named a top 100 hospital, whatever. Should people put much weight in that?
No, I think those are joke ratings. They don't mean anything. In general, those ratings on anything from universities to hospitals are based on pseudoscience at its worst. They decide what's important, but it's not even based on science. So, rating healthcare administration programs, one of the key variables they look at is how many students do you have? Oh, so bigger's better?
Right.
How is that true? No.
Right.
So, to me, healthcare is very individual. When I go in for my healthcare, I really don't care about the statistics. It's me. If you give me a healthcare infection, that's 100%. Okay, I got it. I'm not happy. It's one of these things that you really, really, really need to talk to not only your doctor. A lot of times your doctor knows. The problem is many doctors now are employed by the hospitals. So it's really hard for them to say, well, actually the hospital down the street's got a better infection rate. They're not going to say that. So it's nice when you get a doctor that actually is more independent, but the world has changed. I think I saw, you might know better than me, David. I think I saw like 90% of doctors are now employed.
Yeah, it's a high percentage. It might be as high as 90, not necessarily within a hospital, but maybe in a corporate, because a lot of those physicians might be employed by I'll call it a chain. That's probably not the right word, but an investor-owned or investor-backed medical group. But yeah, the days of the independent doctor who kind of runs their own office seems to be behind us,
unfortunately.
Okay, so let's go back to the hospital bed. You said they get half an hour to clean the room. To do the job right on a bed, to your mind, would be an hour-long job. So obviously that's upside down. Are there, and I think from what I understand of your work, this is probably a leading question, but are there tools and techniques out there that could improve this?
Well, I'll talk about the tool that I have, but let me actually address the whole room and a tool that's absolutely useless but is being used. So UV light. You may have heard it. Hospitals love to advertise. We've got these little machines that cost anywhere from $150,000 to $750,000.
Wow.
And they emit UV radiation. Okay. And the idea being we'll kill the bacteria. They do not work at all. They are the biggest scam that's been played on the healthcare industry in my lifetime. So why do I say that? Well, there's been 2 randomized trials that have looked at it. One of them funded partially by the CDC. Okay. It didn't do anything. It did not decrease infections in C. diff, which was the goal of the study. It did not decrease infections of MRSA, but it did actually, just by luck, if you test enough things, you'll find an answer that you like. It decreased, I think, VRE, one teeny piece. It doesn't do anything. So why is that, Dr. Okay, why do people use these lights? Well, they're easy. You roll them in the room, cut them on, okay?
Right.
But if you just, again, basic physics, okay? If I take a UV light and I put it a centimeter or an inch away, okay? Which is how they test them, by the way, in the laboratory to say that it's going to work. So I put it on there, and they put some bacteria on a metal plate and put it an inch away, and they beam it, and guess what? It kills all the bacteria. Great. That's wonderful. That's in a lab. But just basic physics, the further you get away, the less it does. You get a foot away, it doesn't do anything. You get 6 feet away from the bed with that unit, you don't kill anything. It does nothing. This is basic physics. It just cannot work. You'll hear people talking about using them in air systems. That actually works because the bacteria and stuff are floating right past the HVAC system. Wonderful. Put one in your hospital. I have no problem with that. But please do not put these stupid, I call them R2D2s because they look like little R2D2s being rolled around the hospital. They just don't work. They are the biggest ripoff on the planet. And
do you think that is, sorry to interrupt, but do you think that is because perhaps, I think now it's pretty well known that UV being outside has detrimental effects to the COVID virus. And so people meaning hospitals want their patients to feel safe.
But it doesn't do anything to COVID.
It doesn't do it for COVID either. Okay.
Okay. It's not going to kill any virus from a foot away. It's just not going to work. This is basic physics. You just know it can't work. And there's no studies to say it does work. Okay? Because again, all the studies that have said UV works are in that lab 1 inch away. Well, that's not how they use the units. Okay?
Right.
And the second thing is that you'll hear studies, people will publish a study and they'll say, well, we put the UV light in the room and we decreased our infections. We put them in all the different rooms. Okay, well, doc, why does that? Well, it's because they were cleaning so much better during their study. So cleaning is the key, all right? If you go in and basically drown your room in chlorine, Clorox, bleach, yeah, I don't care. You could roll 3 or 4 R2D2 units in there claiming they were doing it. They didn't do anything. You cleaned better.
Right.
Okay? And so that's what most of the studies are actually doing. The randomized trial that was done, it was called the Better D study. And the UV people will quote and say it worked, when actually, if you read the study, it clearly was an absolute dying failure. But they actually showed that they basically made sure the cleaning was equal between the teams that used the Better D and didn't use the Better D light.
Right.
So when you control for those things, boom, the thing doesn't work at all. So these UV lights, useless, worthless, total waste of money, and need to go away. Okay, they really do. And there are a lot of hospitals that have stopped using them. They've realized this is a waste of time. I already have my people overworked, and now I'm going to make them roll this UV light that does nothing. Yeah, why don't we get rid of it? Yeah. So you got to clean better. That's the key. We talk about antibiotic stewardship, which to define that means not using these big gun antibiotics that basically wipe out your normal flora, and then these big ugly bugs called like C. diff overgrow. So antibiotic stewardship, you'll hear that all day long. That's key, and if we just do a better job, and it's important. But I would say it's probably not even close to the most important thing. The most important thing is not putting people in a sewage, okay? Right. I mean, bottom line, if I told you I was going to dip you in a sewer and hope you didn't get an infection, you'd go, are you an idiot? Well, that's what we do. We dip people in a sewage called a hospital bed, okay? So why do I say that? Well, the hospital bed manufacturers, the major manufacturers of hospital beds, they say you should clean a bed in the following manner. This is across the board. You should pre-clean, which means get the big pile of poop or the big bunch of blood off. Wipe that off first. That's called pre-cleaning. Then you're supposed to clean. Then you're supposed to rinse with water. Then you're supposed to disinfect. Different step, not the same as cleaning. Then you're supposed to rinse again. Then you're supposed to check the bed for failure as the mattress failed, which, by the way, we can talk about that in a minute. Lots of them have, okay? So that's the step process. That's why it takes 45 minutes to an hour to clean a bed.
Gotcha.
Okay? This is from the people that make the beds, all right?
Right.
And this is the approved process through the FDA to say that bed is ready for the next patient. It's called reprocessing. Well, nobody does that. I've done a study. I was at the national meeting. I asked all these people, teeny percentage, 4% rents, only about 10%, 15% inspect, and almost every one of them said they had bed failures. Okay, so nobody's cleaning. Everybody's taking this single wiping down. How many? Anybody's been in a hospital, has been in a room, has watched someone clean, and they literally take one wipe and they wipe the whole bed and the rails and all that stuff, and they're just literally spreading the bacteria all over the place. They're not cleaning, they're just spreading. So they are violating the manufacturer's instructions for use, which the Joint Commission should shut them down over. Okay, they're the people that accredit hospitals. Right. And if the Joint Commission would get off, well, it'd be nice. If they would do their job, they would start saying, you're not cleaning correctly. So if hospitals would clean correctly, I think we would cut infection rates so small it would make everybody happy. We would save thousands, tens of thousands of lives. And yet people won't do it. And why is that? Because they don't have enough healthcare housekeepers. They don't have enough. They need beds, and they need them right now. They can't be waiting hours for you to clean the room. And so, therefore, we're having infections.
And I think part of that, I read an article out of Texas a couple years ago where a hospital, I think bravely, publicly admitted that they basically get paid more when there's a problem because you have to come back, right? Now, there are some new mechanisms for those listening that will prevent some of that, called readmission, penalties and so forth, where if you have to come back and get admitted, the hospital may not get paid a second time. So just if you're not aware of those out there in the public and you're listening, some of that does exist, but there is an element of there's perverse incentives here, right? Where we're not paid as healthcare operators to do that as thoroughly as possible, which when I hear the numbers that you're talking about, when you go through this process, I didn't know this 5-step process that the manufacturers recommend. When I hear this, it's just like, how do we let it happen? And one of the ways we let it happen is that people follow incentives, and the incentives are not aligned.
Right. They follow the money. So you're right. There is starting to be increasing disincentives to not cleaning well. So now you've readmission some of that there. If you're in the bottom 25% for infection rate, so you're the worst 25%, you lose 1% of your Medicare dollars. Okay. So they hold that back. And so if you're in the bottom 25%, you lose that. So, and that can be serious. So a typical 300-bed hospital probably bills $200-300 million a year to Medicare. 2 to 3 million. I know an academic medical center, I'll be nice, in Virginia lost $6 million because they were in the bottom. So that's starting to have a little bit of effect, but it's not enough. As you said, if somebody gets a C. diff infection, if Medicare would do what they claimed they were going to do, which was basically pay not 1 red cent more, that's it. Too bad. Have a nice day. You shouldn't have let that happen. Then all of a sudden the incentives would align. But right. I also would be hated by every healthcare administrator in the United States if I was able to push that through. So I don't know when that'll change.
I think that, and we'll stay off of the policy discussion. We'll come back to beds in a moment, but I will just say, I think that increasing transparency over the last few years through websites, through social media, whatever, is probably healthy on this front. But this is a big ship to turn. The healthcare industry in the United States is a several trillion-dollar industry, and I don't want to defend the number of healthcare acquired infection-related deaths, but I also want to say I think it's obviously going to take a lot of energy and effort to turn this ship.
It certainly is. And I want to state again, I think most healthcare administrators that I know, and I know a lot of them, are mission-driven, wonderful people who never in a million years would want to put a patient at risk. Never.
Yeah. I wouldn't imagine that this is something. It's hard for me to envision like the evil mastermind in their office with their big, admiral's desk, feet up on the desk and a cigar. Like, oh yeah, let's give people more infections.
Right.
I don't think either of us is talking about that. I think we're talking about just that consequence of a system that doesn't have incentives aligned on this. And the other thing, I mean. I've seen since COVID has wound down in public an utter failure of the average person to maintain hand washing, right? For example. And we've known for 100 years that hand washing fights infection. The last 2 years has been a study in how much you should wash your hands to protect yourself just in the general public. And I think that for whatever reason, despite knowing this, both generally and specifically in healthcare, the cleaning, you've reiterated several times, it's all about the cleaning. Something in our human brain just, I don't know, it's like it doesn't let that knowledge sink in.
Yeah, it's interesting. So hand washing is another very important thing in controlling healthcare infections. As I mentioned, if the bed's already clean and I touch it with my hands, I don't get my hands infected. So I think the environmental cleaning is probably the biggest issue, but hand washing is clearly an issue. The studies have shown when people didn't know they were being watched, okay, if I ask you, do you wash your hands every time? You're going to say yes, okay? So those are silly studies. So, but if I go and put a secret shopper and watch you while you're doing your job, less than 50% of doctors and nurses wash their hands correctly. So what do I mean by that? You're supposed to either wash your hands or use alcohol, disinfectant before you touch the patient and after you touch the patient. Okay. I actually do it every time. I really do. And everybody's going to say, oh no, Dr. Hooker's just bragging. No, I really do, because I know how important it is. And it's just become my routine. And I think the problem is people will say, oh, I didn't have time. I was trying to save someone's life. I literally just had to jump in. Well, if you save their life but kill them with an infection, you didn't win the game. Okay.
Right.
So I think we need to realize there's always time to wash your hands. There's always time to either take a squirt of antibacterial and put some gloves on if you're going to do some sort of invasive procedure, like even as simple as an IV. I mean, come on, IVs get infected. So really important, can't be overemphasized. I don't know exactly how we change it, but I used to teach, I've taught many times at med schools, and I would just literally ride the medical students up one side and down the other. You will wash your hands. I always tell them, squirt in, wash out. Like I work in a clinic, there's a sink in every room. So I wash in and wash out. Okay, fine. It doesn't matter. Washing is better. The hand sanitizer is cool. It's quick. And if that's all you have time to do, fine. But it's not as good. And guess what? It doesn't kill. C. diff. That nasty, horrible infection, which is our worst one that we have had the least amount of control over in the last 20 years. It's the one that we've made great strides in other ones. That one we have not done so well. And
so tactically, you mentioned earlier, hey, and the healthcare finance people jumped at us, but you said, hey, try to have surgery if you need it in a non-hospital setting. That's a tactic that the average person can use. Another tactic, sounds like is kind of self-advocate. And if that person, that nurse, that respiratory therapist, that doctor, whoever comes in the room and doesn't wash their hands or at least use the foam or whatever, say, hey,
Well, that's the
you need to
problem.
clean. Or I mean, I imagine a lot of people are going to feel uncomfortable self-advocating in that way, but that is a tactic that people could try.
Well, it's a tactic that you have to do at the culture corporate level. So what I mean by that, if I ask you as a patient, don't let anybody touch you unless you see that. What you just described, which I think is fantastic idea. Now you just made the nurse mad. You just made the doctor mad. And you're worried that I'm going to get substandard care. You won't, but you're still worried about it. Okay. No doctor is going to give you bad care because you asked them to wash their hands. Okay? Right. It's not going to happen. But they may not be happy with you. So what you do is there was a hospital in the Northeast, and I wish I could remember the name of it. I saw a news story on it. I didn't actually see a published article. And what they did is they put a sign up. Everybody, when you signed into the hospital, they said, you now are mandated to tell every one of our healthcare providers to wash their hands. If they don't, you tell them to. And they just changed the culture of the hospital. They said, no, this is what we do. And doctor, if you don't like it, too bad, because we've told every patient that they have to do this because they have to protect themselves. So what I do is, again, who can make a lot of big changes? Board members of a lot of these hospitals. Okay. All they need to do is call their CEO and say, wait a minute, I heard this podcast. Why aren't we doing that here? All of a sudden the CEO doesn't have a choice because his boss is the board.
Right.
Or her boss is the board. And you know what? It'd make a big difference. And so I challenge the board members to push their administrations to say, no, we're going to change it here at XYZ Hospital. We're going to become the hand washing kings. We're absolutely going to do it. And you know what? Every doctor is going to have to buy into this, every nurse, every respiratory therapist. And you know what? It really wouldn't be that hard, and it would make a major change. And I think you could save lives with something so simple. And this one's not expensive. You're going in and buying a $750,000 R2D2 UV light that doesn't work. Why don't you go spend $100,000 on signage and a couple of training sessions, and boom, you could decrease the infection rate really. So.
Right. And I'm pleased to work for an organization that is shooting for what's called zero harm. But it seems like not everybody is shooting for that. So I'm sure you've heard of that. Can you break down that concept for the audience and maybe your thoughts on why that's not a target at every hospital?
Well, I think it is actually a target at every hospital. I just think some organizations realize that you can say it or you can actually do it. Okay.
Right.
A lot of organizations have got so many things going on that they say it and they want it, but they aren't carrying it through completely. So you mentioned IHI, and they did a wonderful job, and Dr. Berwick, and he basically 100,000 lives. And basically he just went after some simple things like having a timeout, and Dr. Tul Gawande also has published on this.
Yes.
A timeout before you do surgery. Wait a minute, stop. Do we have the right patient, the right procedure, the right equipment? Is the patient ready? Is everything safe? Boom. Simple, but powerful. Saves people from dying from a mistake, harm.
Right.
But, I think that there are very few hospitals that are emphasizing cleaning and hand washing the way they need to. If they could put some effort into that, that's where you're going to be decreasing the harm.
Right.
So it's just making sure that I had example, my mother called me. She was in the intensive care unit. She's in heaven now and relaxing and watching down, but she was in the intensive care unit with a heart attack. And she said, I called her on the phone because I couldn't quite get there yet, and I was going to have to fly in. And so she said, this catheter is driving me crazy. I'm like, what? Someone, for the convenience of the nurses, had put a catheter in her bladder. You got to be kidding me. So she could have gotten, in fact, she did get an infection. Fortunately, it cleared up with antibiotics. But she got an infection because somebody thought that, she was peeing a lot and she's had a heart attack and we don't want to make her get on a bedpan. No. So they put a catheter in. People die. Thousands of people die every year from catheter-associated urinary tract infections. Okay? This is not teeny numbers. This is big numbers. So putting in a Foley, and when I did all my training 30, 40 years ago, we put Foley catheters in people left and right in the hospital. Now, if you're a good hospital, you try to never put a catheter in. And if you do put one in, you try to get it out as fast as you can. And I'll bet you the hospital you're working for has a nurse-driven protocol. What we realize, we don't even want to wait to call the doctor. The protocol says there's no reason for that catheter. That nurse can pull it without a doctor's order, period. Our nurses are professionals. They should be allowed to do that, and good for them. And so I talked to the nurse. I said, get the catheter out of my mother. Well, I'll have to call the doctor. I said, no, you don't. I actually know the corporation you work for, and you've got a nurse-driven protocol. I want that catheter out right now. And so she did pull it. And guess what? My mom had a urine infection because they put it in, but it cleared up. The point being, they'd left that in a couple more days. She might have died of an infection that was totally preventable. Can't do that. So the zero harm is saying we have to always think about everything we do and make sure we're not doing things that could put someone at risk. So if you can't get an IV in someone, people want, I'll put a central line in. Well, those kill people from infections. Well, no, wait a minute. Can we do something else? Maybe we can put what's called a PICC line, where I put a line up through the arm, right through the elbow, right above the elbow. Oh, okay. Now every hospital has a PICC team. So we can massively decrease the amount of central lines being put in. And so people don't die of central line associated infections. So there are things that hospitals can do that say, hey, wait a minute, before we do something that could potentially kill somebody, let's stop. A simple one years ago, and I don't think any hospitals do it anymore, is we used to shave people like they were plucked chicken before surgery. I mean, we'd cut every piece of hair, shave all the hair off. Well, guess what? That increased your infection rates once you cut the skin, because you've given all this bacteria get in there and inflame. It was the dumbest thing in the world. Now, I don't think any hospital, I hope no hospital on the planet, shaves anybody. We clip the hair. If you need it short, fine, clip the hair. Okay? Simple thing, decreasing harm.
So much inside of there that you just mentioned. So many other infections and thoughts and concepts. So what I'm going to do is actually back us up to the beds, because we got partway through that and then went kind of down a rabbit hole, following some other thoughts. So you mentioned the 5 steps recommended by manufacturers of hospital beds.
Right.
You mentioned that it is typical, and I've seen this personally, that a hospital bed might be cleaned with fairly intense, chemical wipe, but still one wipe, it's probably not enough. So what to try to, is it just a matter of the time and effort that needs to be put in? Are there other tools that could be used to try to add speed, since this, as we said, the incentives, the mandates for turning over beds, for staying at capacity, those aren't going away. So is there something else besides just spending the time?
Well, a couple of things. First of all, beds used to be made of vinyl, the mattresses, just like the vinyl seats from a 65 Chevy, okay? And you stuck to them in the summer. You peeled yourself off of them. Well, that actually was leading to bed sores. And so all beds were changed in the 1990s to be made of this very thin, breathable fabric, okay? It's got what we call moisture vapor transmission. So it's weird, but it'll let moisture through, but it won't let water through. Kind of a cool idea. So good technology, high tech. But now the mattresses used to be about a 1/4 inch thick. Now they're 1/40th of an inch thick. That is so thin, it's not even funny. Okay.
Right.
So these mattresses are are easily damaged by somebody with a x-ray cassette. Boom, you'll tear them. But more importantly, they're being damaged by the chemicals. That's why the chemical is supposed to be rinsed off. Okay. And if you leave it on there, it destroys the polyurethane that these mattresses are now made of. So these mattresses are damaged. There's been 3 studies, and I just published one last year, looking at damaged mattresses. The study we did showed 72% of the mattresses were damaged.
Wow.
And had leaks, and 50% of them, or actually about 25% of them, actually had blood and feces, or urine and feces and everything inside of them. Stained mattresses. They were dangerous. They literally are a source of infection. Okay. The rest of them had little holes in them. Some of them had big holes in them. And so and that's at hospitals. We're the 3rd study, and all of them have shown the same thing. Hospital beds are damaged. And it's not just old hospital beds. We've showed damage in beds as early as 1 year. Okay. So these beds are damaged, so they can't be cleaned now. You could do everything correctly, do the 5 steps. You're not going to be able to clean it if I've got bacteria down inside that mattress and I'm only cleaning the surface. And then I lay on it, and the bacteria and blood. The FDA had, 5 years ago now, had 700 reports of blood coming back onto patients out of beds. Okay. And if they had 700 reports, there were 70,000 that weren't reported. Okay. So the mattresses, a lot of hospital mattresses have failed. They've just failed. So they need to be replaced. But part of that 5-step process that the hospital bed manufacturers recommend is opening up. There's a zipper on the side of most mattresses. You open them up and you look inside, and oh my God, there's blood in there. Out of service. You also need to shine a light through the mattress to see if there are any holes, because if there's a hole, soon enough, there'll be blood inside that mattress. Right. So beds are supposed to be inspected by the CDC rules, the FDA's rules, and by the manufacturers. And almost no hospitals do it. Okay. So, all right. Well, so hospitals need to find out their beds that have failed. But what could we do? You've got this process that takes 45 minutes to an hour. Is there anything we could do that would shorten that to allow us to turn the beds over? And I work with a company, Trinity Guardian, that manufactured a hospital mattress cover, but it's actually we call it a bed barrier, because it actually protects you from not just the mattress, but it also protects you from the frame. So it actually goes over the frame. So this goes on the bed. It is cleaned before use, and we've shown that we can remove everything off of it because we put it in a laundry. No individual wiping. We actually put it in a laundry machine.
Right, wash it.
But much bigger to the one you have at your house.
Right.
Okay, it's called a pony washer. So we put it in there and we clean it, and it comes back just absolutely clean as can be. Okay. I don't want to say sterile, but we put literally billions of C. diff spores, bacteria, poop, and blood all over these mattresses, and they came back completely with nothing on them. Okay. So can't use the word sterile, but it's very clean. Okay. So you put that on.
Much cleaner than the manually washed bed in the room. Certainly. 100%. Yeah.
So easy. Goes on there. You finish. I just was in the hospital, and the president of the company had his daughter deliver one to me. We put it on the bed, and when I left, we unrolled it off the bed and sent it to be washed. So it is washed between every single patient. So every patient ends up with a clean bed surface. What a concept, okay? And it costs, by the time you clean it and lease it and all that stuff, about $6 per patient. Are you kidding me? We spend more than that on the Kleenexes on the counter, okay? Ridiculous not to do this, and yet hospitals we've got a number of hospitals are using them, but it should be everywhere because, again, I'm fine if you want to spend the 5 steps and the 45 minutes to an hour.
Right.
Great, that's fine. But if you want an engineered solution that takes 2 minutes to put on, that seems like a better deal.
Yeah.
So, and by the way, add it even on top of that, it protects the bed that cost you about $35,000 now. So if someone brings an x-ray cassette, no problem. Somebody puts some chemical on it, not a problem. It all gets washed off. So now your mattress that is actually by the American Hospital Association standards supposed to last 5 years. There's not a mattress out there that lasts 5 years. They're barely lasting a year. Okay. Now that mattress is going to last 5 or 10 years because it's not being destroyed.
Right.
So you're going to get a return on your investment very quickly when you stop having to replace these mattresses. As I said, a lot of hospitals aren't replacing mattresses that are damaged. Again, we went into this one large academic health system, and they were just appalled the shape their mattresses were in. They couldn't believe it. And I can show you the pictures. You ever want to be completely grossed out?
No, I'm good.
Yeah.
There's a reason I went down the non-clinical route in my career, and you just hinted at it. So I'm assuming amongst you've got 80 publications. We said in the intro that some of those are around the efficacy of this tool that you've helped to co-develop. So if folks want to check that out, we'll get them the links and whatever later on.
Yeah, the best idea if you ever want to do something, and I tell people this, again, most people watching this podcast aren't going to be a physician, and they're like, well, I couldn't read the article. Actually, you can. And the key is to go to what's called Google Scholar. If you look Google Scholar and then just type my name in, and if you want to, you can put infections so you don't have to see all the articles I've published. Boom, every article I've published on infections will come up. And you can click on it, and now almost all of those are open access, and you can actually read them. So
that's great. And well, let's talk about that a little bit, because we talked a little bit, offline in prep about, okay, you do this for a living. You teach epidemiology. You're well published. You know how to look at a study and say, is this malarkey or not? What are some things the average person needs to know if they're looking at a study in general, whether it's hospital acquired infections or more broadly? Because I think this has been the 2-year journey of the whole world trying to figure out what the heck is a good study or not, right, with COVID. So not asking you to point specifically to COVID, but just how does somebody tell if they're looking at something peer-reviewed doesn't necessarily mean it's a great study anymore, right? So how can people tell?
Well, it's hard. I'm not going to say it's easy. What I would say to people is, first of all, listen to reputable experts. And I think a lot of people have questioned the CDC because their recommendations have changed over time. They've changed over time because of changing information. Okay. Mm-hmm. So, they really want to give you the best advice. Okay. So I think you can listen to someone like Dr. Fauci. He reads it all and he's looked at it all. You had a lot of different cures. And again, I don't want to go down any specific,
sure.
Politically motivated stuff, but there were a lot of things recommended by pundits, even sometimes by physicians, that had no evidence at all that they worked. Don't be listening to people like that. I'm sorry. If the CDC is telling you that XYZ treatment is got no credible evidence that it works, then I wouldn't do it, because we talk about the ultimate study is a randomized trial. So like I was talking about UV light, the randomized trial says it doesn't work. Okay, period. And again, the manufacturers are going to hate me and they're going to say, oh no, it did decrease this one little infection, but no, what was the goal of the study? The goal was to say, does it decrease C. diff infections? And it did. Okay, end of discussion. So randomized trials, what they do without getting too far into the science is they control for everything. Okay, so if you are trying to decide whether or not something works, you don't want extraneous factors to be involved. Okay. Right. So think of COVID. If I'm trying a treatment, I don't want it to be that I gave it to a bunch of people that weren't that sick and they were going to do well anyway and they all survived. So I say my treatment works. No, I need to make sure that I'm comparing groups that are equal in every other way except for whether they got this drug or not. Okay. Right. So all the vaccine trials, everybody was randomized so that the two groups were totally the same. It's just half of them got the vaccine, half of them didn't. Perfect. You can listen and believe a randomized trial. Okay. Those are the best if they're done right. And occasionally they aren't. But in general, if it gets to a reputable journal, okay, this is peer reviewed, and it was randomized trial, it's pretty daggone good. Okay. I'm sorry. It's pretty good. And so, but we can't wait a lot of times for that. Okay.
Right. It's take a long time.
Is a great example. I mean, it happened so fast and we had to make some decisions with some very marginal evidence. Okay. So, but ultimately the final answer should be randomized trials. But observational studies are good. And you can do statistical ways to control, but it gets too complex to try to train Joe average citizen on going through all this research. So I really think you have to lean on the experts that don't have any political motivations. Okay. Right. The CDC, again, nobody's perfect, but they really do try to do the right thing. And they're trying to stay apolitical as best they can. It unfortunately seemed to become political, and they've tried to get away from that.
Right.
So they need to be independent. NIH needs to be independent, and they need to be making decisions based on what's best for patients. So I think listen to experts. A lot of people say, well, listen to your primary care doctor and stuff. There was some real, I don't know what the right word, unethical people that were pushing political agendas, but they had MD after their name. Oh, come on. Be careful. If your MD is saying a bunch of stuff that NIH and CDC says is wrong, I'd start questioning the whether that doctor is really who you ought to be with.
And there's probably some realm, because I don't know if this is true. I read it a couple years ago that something like 10,000 globally, 10,000 new studies, I don't know, a day, a week, a month, whatever.
A month, I think, is the number.
Yeah, nobody's keeping up with that. It's not humanly capable. So it's very possible, I think, I don't think I disagree with anything you said. I think and I think it's good information for people, but my caveat here at the end is just the sheer amount of science that gets published every day means people can make mistakes. They can think they're up to date and not be up to date. And that can be your primary care doctor, to your point. That could be the CDC. That could be whoever. It's just that mistakes can be made, and particularly when we're talking about something as rapidly evolving as COVID was and is. There's going to be new science all the time. When it comes to hospital infections, healthcare acquired infections, as we've been talking about, I'm sure we've been studying those for a longer period of time. So the science is probably a little more stable there. Yes. And so people can probably take refuge in that at least.
Yeah. But I mean, the thing is like, you look at the experts at the CDC, they're not trying to be experts in everything.
Sure.
One scientist or a group of scientists, they know Ebola, and that's what they know. And they actually do read every single article that comes out on Ebola. I read every single article that comes out on hospital-acquired infections related to environment and beds and all. I read every one of them, okay? So I think that's what you're looking for. Okay. You're to your point, it's impossible for me to be an expert in cardiothoracic surgery. I don't have
Right.
time. Okay. But so you're asking a family doctor to be an expert in an area that they just can't be. There's no way that they have the time. They're so busy and so wonderful, and we need wonderful primary care doctors. Do not get me wrong, but you can't expect them to be an expert in some subspecialty thing like hospital-acquired infections or like Ebola or COVID.
Right. So now that we've scared everybody out of the hospitals and out of getting surgery, I suppose it would be the responsible thing for us to point out that, or to talk a little bit about, there are, while hospital acquired infections, healthcare acquired infections are bad, we don't want them. We want to do the tactics that we've talked about to avoid them. We want to encourage our local hospital board members, if we're friends with them, if we are one and we're listening, to push for more sanitary healthcare conditions. But there's a lot of things out there much, much worse than a hospital infection, chest pains that we ignore for days, things like this. So we probably should emphasize that you do need to take care of yourself.
Absolutely. I think, I tell people the only way to assess chest pain is in an emergency department. I'm an emergency physician. I'd love nothing more than to tell you I see no evidence of anything serious and we'll be sending you home. I love that. But when I really sad is when I hear the husband or wife say, they've been having chest pain for 3 days, but then they collapsed and we're doing CPR and we're not going to save them. That makes me very sad. Or somebody with numbness or weakness in an arm, or a face, or can't talk, and they're having a stroke and they wait hours. We have drugs now that I can reverse strokes. I can totally save you. You won't be paralyzed at all. But if you wait 3 or 4 hours to come in, I can't. So I tell people, listen, get to the ER right now. So, that don't let this stop you from coming to the emergency department. But do realize that sometimes someone will say, I'll diagnose you with pneumonia, or I'll diagnose you with COVID. And I'm like, and I'm going to be sending you home. And people are like, well, you should put me in the hospital, so I can be watched. No, actually, the last place you want to be, if you don't need to be, is in a hospital.
Right.
So I think a lot of people need to understand that when we're sending people home, it's because we know that people get sick in hospitals. Okay.
Right.
Hospital-acquired infections are there. Okay. So this is why we want to always treat everybody as an outpatient if we can.
Right.
But this should help people also come quicker. The sooner you come in, the less medical care you'll need. This is really important. If you come in with your infected foot before it's now in your bloodstream, which we call sepsis, I probably can put you on antibiotics and send you home. But if you wait until you have sepsis, I'm going to be sending you to the intensive care unit and hoping to save your life. So please seek medical care early. Go to your wonderful primary care doctor, okay? A lot of these primary care doctors, they take a look at your infection, get you on antibiotics, and you're done.
Right.
And you never even had to go to the ER. The ER is there. You should seek care. But if it's, Monday afternoon at 1 o'clock, why would you want to go to the ER? Go to your primary care doctor who can treat you a lot cheaper. Okay. The copay on an ER is a lot of money. And it's early. And so it doesn't need all this intensive therapy. But don't go to your primary care doctor if you're having chest pain going down your arm. Please go to the ER.
Right.
911, please.
Yeah, absolutely. Well, Dr. Hooker, there's a lot we've talked about. There's probably a large number of things we could continue to talk about inside some of these topics. I mean, you alluded to how nasty some of the bugs have gotten, the super bugs. We could probably have a whole conversation just on super bugs, but I do appreciate what we have had the chance to talk about. If people want to find more of your papers, we talked about this a little bit, but if they want to find more of your papers, your thoughts, where can they find you?
Well, again, I'm always delighted to speak with a group about all this. So they can always contact me through Xavier University, which is my main place. Edmond Hooker at Xavier University. My email is hookere@xavier.edu. Then Xavier, we spell it with an X, Xavier. Sorry, that does confuse some people, But anyway, I'm always delighted to answer questions. I'm very passionate about trying to decrease healthcare-acquired infections. If there's a hospital CEO that wants to talk to me, I will give you my unbiased opinion, and I will give you the thoughts. I'll share all the research with you. I'm delighted anytime somebody says, listen, I'd like to see all of that research. Great. I'll send you a long list. I hope you got a lot of time to read it, but it's very important. We all need to work on this. And if I can decrease one hospital-acquired infection, I just saved a life.
Right. Well, I appreciate your passion to make that positive difference. I appreciate you taking time out of your busy work and your busy day to join me here on the No Bad Questions podcast. Dr. Hooker, thank you very much.
You're very welcome.